Hi, good morning. I'm Dr. Victor Politi from National University Medical Center, and I'd like to welcome you and thank you for tuning in today to Health Talk. I'm the president and CEO of the National University Medical Center there on Hempstead Turnpike, that big building over there. And we're just glad to be here today. I mean, healthcare today in America is changing, and we at New Health at National University Medical Center is part of that change. So we're going to have a half-hour program today. We'll provide you with some essential information about our services and facilities that provide a top-quality care that fits into your lifestyle. But we've been around for a while. New Health has been here since 1935 as a small 200-bed general hospital. But now it's become a unique health organization, multiple centers of care, and a commitment to deliver excellent essential care to everyone at every stage of life. So you may know us already, Nassau County's premier Level 1 trauma center, but we have so much more to offer the community, including a full-service, state-of-the-art center of health here at Nassau University Medical Center, an A. Halley Patterson extended care facility in Uniondale, and we have a series of New Health family health centers throughout Long Island to provide primary care to your family. Our improvements are making us a leading provider of primary and tertiary care services that rival the best in the country. Well, today we have a pleasure of Dr. Venk, and Dr. Venk is our Director of Bariatric and Minimally Invasive Surgery. And this is something that's really catching on around the country, not only for obesity, not only for cosmetic reasons, but a lot for medical benefits that patients receive from weight loss and from control of diabetes and other health problems. And so, Dr. Venk, I really want to thank you for being here. It's a really interesting subject, and I'm sure a lot of our listeners have heard about bariatric medicine and minimally invasive surgery and stomach banding and all these other things, but really don't know anything about it. So hopefully over this half hour, we'll explain it in simple terms to these listeners so they know what it is, and maybe they could follow up. I mean, just so you know, we're at New Health, and the website for us is www.newhealth.net, or we have a phone number for National University Medical Center, which is 516-486-NUMC, that's NUMC, National University Medical Center, or 486-6862. So, Dr. Venk, welcome, and thank you very much for being here. And why don't you tell us a little bit about yourself first?
Yeah, thanks for having me, Dr. Politi.
Of course.
I was born and raised in India, and I did my med school also in India. And in 2002, I came to the United States. Now, I was listening to a few of your previous guests, and they all said I was born and raised in Long Island. And I thought I'll pull that off, too. I'll say that I was born and raised in Long Island. But as I was contemplating that, my daughter asked me a question. She asked me, and the answer was, baby, there is no atmosphere in space. And she said, Dad, did you mean atmosphere? And I said, yes, that's what I meant. So then I realized that I couldn't pull it off.
You'd say from Brooklyn.
So yes. So but I've been in Long Island for 12 years. Mm-hmm. So I guess I could rightfully call myself as a Long Islander.
Oh yes.
And I did my surgical training at North Shore LIJ in Manhasset for 5 years. And after that, I went to New York Medical College, Westchester, for my training in minimally invasive surgery and bariatrics. And then in 2008, I joined NUMC as attending faculty in minimally invasive surgery. And 2010, I took over as the director of bariatric surgery, and for the last 4 years, I've been running the program.
And those are pretty impressive credentials to go to school in India and then come here and get a top residency in surgery, and then to get a really coveted fellowship in minimally invasive surgery and bariatric medicine. You must have been really at the top of your class. And you know what, Dr. Venk, I've known you now for a while, and yes, you certainly are a Long Islander, and there's no doubt about that, and we welcome it. We're very happy, and we're very pleased that you should be on the staff at National University Medical Center. And I go out and speak to the doctors and even all the different departments, and I am always amazed at the quality of physicians that we have in that hospital and that the services that we provide in that hospital. People, over the years may have driven by, they're not really sure what goes on in that big building, or it's the Level 1 trauma center. God forbid you're in an accident or some other horrible event happens to you. That's the place, because there's no place like it. The ER is brand new, $38 million, and we have board certified ER guys. We've got top trauma surgeons that are trained in Harvard and Yale, and they're standing by 24/7, operating rooms, ICU. But what they don't realize besides that are the other services, the cardiology services that we provide, the gastroenterology services, endoscopy services. And I had once, I had Dr. Mustaki here, who's the chairman
Yes.
of our gastroenterology department, and he was explaining about colonoscopies. But now you do bariatric surgery. And that's a little step further than anything that we could think of. So how does one finally or wind up with you? I mean, do they go through a series of diets, or is there something, and then eventually they say, I have to go for surgery? What's that about?
Yes. I mean, bariatric surgery is pretty much the last phase in somebody's attempt to lose weight. So they try all the other means, diet, exercise, and sometimes even medications. And when everything else fails, then they come to surgery. Even though there's data to show that only 5% of patients that are trying these diet and exercise are actually able to lose significant amount of weight. Whereas when you have bariatric surgery, you have a 70% chance of losing that excess weight. But bariatric surgery shouldn't be the first go-to option for people that are losing weight, because once everything else fails, then we help them out with the surgical option.
So you would recommend first dieting, watching your, what you're eating, your caloric intake, following it very closely, exercising some more, and working on your own to do that.
Correct.
But so many people, I've been on a diet my whole life, and I don't lose weight. And so I guess people just try, and when that doesn't work, what would trigger that in? Is there like a certain weight you reach, a certain BMI, or is it a health issue? Like, what would trigger someone to come to you for the surgery?
I mean, there's a lot of things. I mean, I'm glad that you brought that up, because when you're dieting, actually, the odds are stacked against you. If you look at the science, when you're dieting, there are some hormones which are called as the hunger hormones, and those hormones are really elevated. So you can do it for a few days, and then once you give up the dieting, those hormones are still high, and you end up actually having a rebound, and you end up gaining more weight than you've lost. With regards to bariatric surgery, what happens is, we have to look at something called as the BMI. The BMI is a number that is based on your height and weight, and we do a calculation and we come up with some numbers. So if your
BMI stands for
body mass index.
Thank you.
If your BMI is between 18.5 and 25, that is the normal BMI. That is where we want you to be. And if it goes beyond 25, then you enter the world of obesity and overweight. So 25 and 30 is overweight, and anything over 30 becomes obese. And even when you're obese, there are classes of obesity. You have class 1 obesity, which is 30 to 35, and class 2 is 35 to 40, and class 3 is anything over 40. So surgery has been reserved for people in the higher BMIs. So if you have a BMI greater than 35, that is when people start considering surgery as an option to lose weight.
So when you talk about the body mass index, a BMI, so it's height and weight. Now, if I'm just listening to this and I'm wondering what my BMI is and I don't want to go to the doctor, is there a way on the internet? Could I look that up? Is there charts? And so basically, I'll just go on a chart on an internet and put in BMI, body mass index, and it'll show a chart, and I'll just measure myself as to height and weight. And lo and behold, I'm at less than 25, so I'm okay. I could just diet and maintain myself and exercise.
Right.
If it over 25 or over 30, said it's class 1 obesity?
Yes.
And then I really should get consultation with physicians and try to get some help in getting my BMI down.
Yes, calculating the BMI is actually even easier than that. You just go to Google and type in BMI calculator, and you have plenty of websites that show up.
Okay.
And you just have to put in your height, put in your weight, and it does the calculation for you and gives you the number.
Gotcha.
But in the present world, with all the importance being placed on obesity, your primary care doctor usually calculates that when you go and visit them. So,
Gotcha.
So they should be able to pick it up, and they should be able to tell you that you're falling in the overweight category or you're in the obese category.
So now I'm obesity, I have diabetes, I have medical conditions. My physician will refer to you, or can we directly call this number at NUMC and make an appointment to see you at 486 NUMC, 486-6862. I got it right this time.
Yes.
So they can call that number directly to have an appointment with you?
Yes, you can have an appointment with us by either calling that number. You can call My office directly, it's 572-6703. That's 516-572-6703. And we also have free seminars every month. It's on the second Wednesday of every month at 5 o'clock in the library. It's on the third floor. And we invite everybody who's interested in learning more about this topic to come in. It's a 1-hour session where we go in detail about obesity, about all the options that are there, and what we do in our hospital.
So you just mentioned options. What options? Tell us some of these options. Now, I'm obese. I've tried dieting. I went to my physician. He says, Vic, you're not doing so good. We got to get you. Your health is failing. Go see Dr. Vank. And what other options, or what else would you tell me to do?
Yes. Well, I mean, once you come to see us, then the first thing that we do is to find out if you're a candidate for surgery. And you would be a candidate for surgery if your BMI is greater than 40, or if you fall between 35 and 40 and you have one of the other conditions like diabetes, high blood pressure, cholesterol, arthritis, headaches, sleep apnea. There's a whole bunch of things that goes along with obesity. So if you have any of those conditions and your BMI falls between 35 and 40, then you become a candidate for surgery. Now, once you're a candidate for surgery, the next thing that we have to find out is if you're motivated enough to actually follow through with the surgery and all the recommendations that comes after the surgery. So we usually ask you to go see a nutritionist, and you'll be seeing a nutritionist ranging from maybe a month to 3 months, sometimes up to 6 months, because some of the insurance companies require you to do that. And once we know that you're going to be a candidate for surgery, then we do a whole lot of pre-operative workup, because now we want to make sure that it is safe to operate on you. It is safe for you to go under anesthesia. So you get to see a cardiologist, you get to see a pulmonologist, you get to see a psychologist, to see if you have any eating disorders. And after all that workup, then you go to the operating room. And during this process, we discuss the various options that are available. In the U.S. today, there are 4 surgeries that is being done. The first one is the lab band, which is the gastric band, or an adjustable gastric band. The second is the gastric bypass. The third is the gastric sleeve. And the last one is the biliary pancreatic diversion. Now, not a lot of centers are doing biliary pancreatic diversion because of the high complication rates associated with it. So we don't do that in our hospital. But we do the first 3 options, which is the band, the bypass, and the sleeve. And they're all done laparoscopic with small holes, keyhole surgeries. So a lay person that is looking at your scars will not be able to see what surgery you had.
It's all minimal invasive.
It's all minimally invasive. And in fact, for the band, you go home the same day.
Same day.
Yeah, we do it in 45 minutes, and you're home the same day. The bypass and the sleeve, you end up staying for 2 nights in the hospital. Yes.
Maybe I'll bring you back again for an extended show. I can have it done right here for the band. So explain. So now, we get in, we go to see you, we make an appointment. Now I'm getting a full checkup. The cardiology is going to do his thing, the pulmonologist. I'm talking to a nutritionist, because it's very important once you have that type of surgery to maintain that, the healthy diet, so you could actually gain weight even after something like this,
yes,
right?
Absolutely. I mean, surgery is a tool to help you lose weight, because what happens is, you're trying to lose weight, you're trying your dieting, you're trying your exercise, and you're pretty much starving yourself, and then at the end of the day, you look at the results, and it's very frustrating. What surgery does is, if you put in the same amount of effort after surgery, you lose about 20-25 pounds in a month, in the first month itself. So it's a sort of positive reinforcement for people. And they shouldn't mistake that for the surgery being a magic bullet that is going to take care of their obesity problem.
Right.
It's not. What it's doing is it's giving you 2 years to change your lifestyle and to change your eating habit and to get an exercise regimen in place that you're going to follow for the rest of your life. Because studies have shown, they did a study where they followed up on these patients for 2 years, and then they looked at what happens at 2 years. 1/3 of the patients that had the surgery, if they had lost 100 pounds, they remained at minus 100. 1/3 of patients lost maybe another 10 or 20 pounds and remained at minus 110 or minus 120. And 1/3 of patients gained all the weight back. Now, these are the same surgeons doing the same operations on these patients. So why the difference between these groups? They found that people that took the surgery for granted, and they said, okay, I've had the operation, I'm losing weight, so I don't have to do anything else. Come 2 years, they're going to gain back all the weight. So people who use surgery as a tool and then change their lifestyle, change their eating habits, they were able to keep the weight off. So people that say surgery is an easy option actually are not right, because they have to put in the effort to make the surgery work. Otherwise, it's not going to work for you.
Yeah, there's no magic bullet like you said.
Yes.
But I think, you try to diet, you look at the results, instead of losing weight, you get on the scale, you gain weight. So I just starved myself for a couple of days, because you're putting on water, your body's changing, metabolism changes, your body starts to hold on to its fats and goes into ketosis and all that.
Yes.
But, when you do something like a bariatric surgery, now you come out of there and you've already lost, a certain amount of weight, you're sort of motivated. Psychologically, it does so much. You put on your suit and it's loose on you, and you're going down an extra couple of notches on your belt. Psychologically, now you're motivated to push off that extra piece of cake or get a single scoop of ice cream instead of a banana split,
Yeah.
And that's what you're saying. You need to change your mindset, the way you live your life. Once you feel that way, and I tell you put on a nice thin, pair of jeans, and now they fit, and you're going to say, you know what, I don't want to lose these pants, and hopefully most people do that. But if you do nothing, you're going to gain all that weight back.
You're going to gain all the weight back, and it's nice to wear those pair of jeans that you always wanted to get into, and the advantages psychologically for these patients. Some of these patients don't take public transport. When they're obese, because they don't fit into the seats.
Right.
They can't take the flights because they have to buy two tickets. They can't get on the rides. They don't walk in the middle of the hallway. They don't walk in the middle of the hallway. They try to stick to the walls because they want to be as inconspicuous as possible. So there's a lot of psychological burden that goes with obesity, and to have all that taken off is a big deal. But more than that, what obesity surgery is all about is resolution of comorbidities. I mean, diabetes. The incidence of type 2 diabetes, in obesity is very high. Almost 60 to 90% of diabetics are obese. And if they're able to lose weight, and if they're able to get off those medications, that is a big deal for them. Hypertension, the resolution of these diabetes, hypertension, cholesterol, sleep apnea, the chances of these going away after the surgery is almost in the 80 to 85% range for your bypass and sleep.
Yeah, and people don't realize how important that is to your life. I mean, diabetes, if you can control your glucose, your sugars, you can live a normal life. If you can get off that medication, start cutting back on them because you lost the weight, or your blood pressure, or you just mentioned sleep apnea. Now, sleep apnea, that's a major, comorbid factor in cardiac and ailments and respiratory ailments and early death.
Yes.
So does bariatric surgery help with sleep apnea as well?
Absolutely, yes. I mean, about 80 to 85% of patients with sleep apnea have either dramatic improvement or actually are off of this sleep apnea machine, the mask that they use, after surgery. So, and like you said, sleep apnea is a very dangerous condition. People can die from it. And not only that, sleep apnea, there's a saying, obesity begets obesity. Because a lot of people, when they talk about obesity, they say, this is calories in, calories out. So if you're taking too many calories in and not burning enough calories, then that leads to obesity. That is a very simplistic way of looking at it. There's a whole lot of things that goes along with it, like genetics, right? If one parent is obese, the chances of you becoming obese is 50%. If both your parents are obese, the chances of you becoming obese is 80%. So it has a lot to do with genetics. It has a lot to do with the environment, the way we lead our lives now. And so there's a whole whole group of factors that affect obesity. One of which is also chronic sleep loss. So it's not just eating and leading a sedentary life. So when you have sleep apnea, you're not sleeping well. So that itself can lead to more obesity. Medication, some of the medications you take for your depression, sometimes even for your diabetes, can lead to weight gain.
So in our hospital at National University Medical Center, do we do sleep apnea studies as well? Can we bring you in for sonography tests and see if they're in fact suffering from sleep apnea?
Yeah, one of the things that we really strived hard to do in our program at NASA University's Medical Center is to have a one-stop shop for our patients. So it's not like if you want to see a cardiologist, you're running off to another place. You want to see a pulmonologist, you're running to another office. Everything is under one roof. So from the cardiologist to the pulmonologist to the sleep apnea testing, psychologist, nutritionist, everybody is under one roof. And we have an excellent team, and it's not a big team. It's three of us. It's me, Gerald is my PA, and Nelka is my coordinator. So the patients just have to know the phone number for Nelka. That is it. And she takes care of everything. She gets them the appointments for all these things, and she makes a phone call and tells them, this is the date, this is the time, and this is the place you have to be in. And as long as they can make that, they're taken care of. So it's not like they have to make the phone calls to make appointments. They have to make phone calls, find out where they have to go. No, everything is taken care of by the team.
Yeah, because I know we have some of those studies. We could do that, and so we have the gastric banding,
Yes.
which is minimally invasive. 1 day, 45 minutes, whatever it is that you get in there and you're out.
Yes.
Now, if I have that done, when do you start seeing that improvement? I mean, the banding basically limits the amount of food you could intake, and so now your body loses weight over time. How does that work?
Yes, the three surgeries are a little different from each other. The banding is the simplest procedure, but the way it works is it limits the amount of food you eat. You put a band around the stomach, and then there is a balloon inside the band. You connect that balloon with a tubing to a port or a reservoir that we place underneath the skin in your abdomen. So what it does is it divides the stomach into two pouches. So as soon as the top pouch, which is very small, fills up with food, you feel full and you stop eating. So it is a restrictive procedure, meaning it just limits the amount of food that you eat. With the banding, you lose anywhere from 10 to 15 pounds usually in the first month. And it is a more gradual weight loss with the banding, because all it does is limits the amount of food that you eat. But with the other two surgeries, the gastric bypass, now this is a surgery where you cut the stomach and you make a small stomach pouch, which is the size and shape of an egg. So you're able to eat very little. But what you also do is you reroute the intestines. So you're also able to absorb less calories. So it has dual mechanism of action, unlike the band.
Right.
So you have more dramatic weight loss with the bypass, and you also have an increased rate of resolution of comorbidities with like your diabetes and other things improving is higher with the bypass because of this dual mechanism of action.
Right.
And with the sleeve also, what you do is in the sleeve you only operate on the stomach. You cut the stomach, you take out 80% of the stomach, and you leave a stomach that is shaped like a banana, which can hold maybe about 100 cc's. So what you're doing is you're limiting the amount of food that you're able to eat, but it also takes away 80% of the stomach, which produces a hormone called as ghrelin. And ghrelin is your hunger hormone. So as ghrelin goes up, you feel more hungry. When you take out 80% of the stomach, you're taking out more than 80% of ghrelin. So that also plays an important role in the weight loss. So when you talk about weight loss surgeries, I mean, it's not just limiting the amount of food that you can eat, but there's a lot of hormonal and chemical alterations that are happening inside the body that is going to help you with in this process.
Ghrelin. So they didn't make an anti-ghrelin pill yet, have they?
Not yet. I'm hoping that it'll take a long time.
That would work. Anti-ghrelin.
Because obesity is. I mean, if you look at. I wish. You have listeners, but if this was a TV show, I would show you a chart, and it shows all the different pathways that exist for obesity, and you stop one, another one opens up. So that is the problem in finding medications in order to to combat obesity, because there are too many channels and too many things that you have to deal with in order to come up with an adequate medication.
Is there any follow-up after the surgery or with the banding? Do they have to come monthly or weekly to visit you? And how long does that go on? Is that for the rest of their life, or?
Oh yeah. I tell my patients, this is the time before the surgery, you have to decide whether you're going to have the surgery and if you're going to have the surgery here, because once we do the surgery, it's almost like we're married for the rest of our lives. You cannot get rid of me, and I'm not going to get rid of you. So they're going to be coming back for regular follow-ups.
Right.
Usually we have a schedule. They come in post-op. They come in at 1 month, 3 months, 6 months, 1 year, and then yearly after that. And the reason is, one, we want to reinforce. We want to tell them if they're doing a good job. That is always helpful. And we also want to, more importantly, find people who are not doing well, so that we can catch them early and then see if we can help them out in this process. And the other thing about these surgeries is vitamin deficiency, right? That is one of the things. You will be on vitamins for the rest of your life, 2 vitamins a day. And these vitamin deficiencies don't happen overnight. They creep up. So we want to be able to pick them up early by doing some blood tests. And that's why it's very important for people that are having bariatric surgery to be compliant with the follow-up. And to go back and see their surgeons or physicians on a regular basis.
So that's interesting. Vitamins and iron as well. Is that correct? Because that is absorbed also through the stomach and through the stomach acids.
Yes.
So what vitamins do they become deficient in?
Usually it is iron, like you said, because iron is absorbed in the proximal jejunum. And then you have the ileum, which are the factor 12 deficiency. So you have the vitamin B12 deficiency from that. You have vitamin B6 deficiencies. And then protein deficiency is another major thing that we have to be careful about, because when you're losing weight and you're not when you're not eating enough, your body is going to break up your proteins. It is going to break up your fat in order to provide you with energy. Breaking up fat is what we wanted to do, but breaking up proteins is not good, because protein is essential for you to be healthy. You're going to, your enzymes, your muscles, everything that makes you healthy is proteins. So you want to take in at least 50 to 60 grams of proteins a day in order to give back the body the protein that it needs to build it up. So that is something that is that we also keep a very close eye on.
And you'll do some blood tests to determine as far as that's going. But
Yes.
you would, I guess, instruct the patients, this is what you need to do, and these are the... Now, when you do the banding, do you need to be on the vitamins as well?
Yes.
Banding as well?
Now, that's a good question, because a lot of patients ask me that. Right now, you're able to have a plate of food. After the surgery, you're going to be able to have maybe a quarter of that portion. Now, the question is that small amount going to give you all the vitamins and minerals that you require?
Right.
And the answer is no. So no matter what surgery you get, you will be on vitamins for the rest of your
So
life.
maybe eventually when this catches on, restaurants will have quarter plates, half plates for banding, the banding menu, the bariatric surgical menu. People have much smaller diets, and they don't have to go to a fancy restaurant. Actually, if you go to a real fancy restaurant, they only give you a little bit of food anyway. So
That's true. There are actually restaurants, I heard, in Manhattan, in the city, that have bariatric menus.
Really?
They have small portions, and you don't have to pay for the full entree.
Yeah.
We are actually in the process. We are actually thinking about giving our patients some sort of an ID. And see if they can, show it to the restaurants and ask for a smaller portion
Or a
size,
discount,
or
right,
a
sure,
discount
yeah.
or something.
I mean, because obesity starts at a young age. Like you said, there's genetic components, but environmental components. I mean, the way our lifestyles are today, people are running from one event to the next event. Families, both parents are working. Sometimes 2 jobs, and you're sort of delegated to eating fast foods and all these quick meals, and maybe not as healthy as you should eat. So we're sort of dooming our younger, our children into a world of obesity by not giving them great habits as a young child. I mean, I'm sure, Dr. Vank, you would not be unhappy if there was never another obese surgery that you had to perform, because that would mean that people are healthier. But in America, in our lifestyle, that's not the case. If anything else, we're living in a world of excess.
Yes.
And people are eating too much and eating the wrong things.
Yes.
So
I
you're
agree.
going to be a necessary person around for a while.
Yeah, I agree. I mean, I would be more than happy to give up bariatrics as long as they don't need it, yes. I was just, watching a show on the TV. It was on one of the news channels. They said, this is probably going to be the first generation where the life expectancy is going to be less than that of their parents.
Really?
And obesity has got a big role to play in that. Like you said, the portion of food sizes have gone up. We spend more than, I think, $200 billion on this problem, and teaching there are a lot of programs that that they're doing in the school right now to teach the kids to eat right, exercise, and all those things. And the last I heard, there was a small dip in childhood obesity, and that's a positive sign. And I hope that becomes a reality.
That's what we're hoping for.
Yeah.
So we're here today at Health Talk for the National University Medical Center. I'm Dr. Victor Politi. We're here with Dr. Venk, Director of Bariatric and Minimally Invasive Surgery at National University Medical Center. And the number there is 516-486-6862. Or I think, Dr. Venk, you have a direct number,
512-6703.
6703, that you can call directly for an appointment with Dr. Venk. Again, I want to thank you all for listening today. I hope you have a great day. Stay healthy, and we'll see you in a week or two. Thank you. Bye.